Mark Skender, and I'm with Divine Mercy Supportive Care. And our mission is to deliver medical, supportive, and spiritual end-of-life services consistent with the Catholic standard to anybody who desires it. And it's important to understand what that Catholic standard is. It's something that we've developed that is consistent with the moral and the bioethical issues of the Catholic Church. So our company actually has kind of a threefold approach. We've got the educational aspect, we've got a charitable aspect, and then we've got what will be our medical aspect. And the reason we really need to take this seriously, and it's an uncomfortable subject, people don't talk about end of life, but it is part of pro-life. Pro-life is from conception till natural death. And there's not a whole lot of natural death going on there. There's not. It's really very unfortunate, and we know that we can do something to change that. So like I said, over the last 9 months, we've been doing these presentations, and we've run into all of these magnificent people, and we put this board together now, or this panel. We can't assume that we're going to be able to die in hospice care, although from what I know about hospice care, regardless of the religious aspects, it's really they take care of you in a really wonderful way. And we're going to talk about some of the myths of hospice care because there are some issues, but we can't decide how we're going to die. You know, personally, if I had a choice, I would like to maybe be in a hospice care situation, cognizant, preparing, solidifying relationships with family, with God, whatever. And these are just general facts. First of all, it's important to understand that hospice is not a place. Hospice is a type of care. The majority of people in hospice care have hospice care in their place of residence. So it's kind of really important to understand first and foremost. In order to become eligible for hospice care, you need to be diagnosed as terminally ill or to only be living for at least another 6 months or less. So that's the criteria. An unfortunate fact is that 58.5% of people who are eligible for hospice care never take advantage of the benefit. And hospice care is paid for in a few different ways. It's either out-of-pocket, personal finances, it's private insurance, but the majority of people in hospice care are in hospice care because they're eligible for Medicare. And hospice care is a benefit under Medicare. And a lot of what we've been doing with respect to education is to typically educate people on that alone, to let them know that there are benefits for them for no charge if in fact they're going to be taken care of in their home. So it does raise a couple of pretty significant issues, though, that we're trying to put our arms around it. If the benefit is good for 6 months and you're eligible, if in fact you're diagnosed to only be able to live for 6 months or less, why is it that the average stay in hospice care is less than 2 weeks? That's really disturbing because hospice is a wonderful type of care, palliative care is a wonderful type of care, and people are being almost gypped out of it. We're not sure why. We think there are some myths about hospice care. It's scary, particularly from a family standpoint, almost a death sentence, you know, so all of a sudden your doctor has been treating you for cancer, now you're in stage 4, stage 5, says, you know what, I don't think this hormone therapy is going to work, you know, we're not even going to try it, I suggest you go into hospice care. All of a sudden it's like, you know, no, you know, because there's that myth. Now, do people die in hospice care? Absolutely. But see, it's a wonderful way, if in fact you're there in time, to really solidify those relationships that I talked about earlier. So we think that there's an issue with the fact that people misunderstand what hospice is, and that's what keeps a lot of people out. And I wanted to ask you first, Alan, is there anything that you can think of from a medical standpoint, from a doctor, why the average stay in hospice is 2 weeks? When we have the ability to diagnose people, we understand because the color of their eyes changes, the color of their skin changes, a lot of different symptoms, a lot of different tests that are given to people to let them know you're going to die. Why is it taking so long, do you think?
If you look at the normal history of a person's life and disease process, you can, in the past, especially before hospice and palliative care medicine came into vogue, it was normally a path of always an effort towards a cure. Your efforts towards healing a person was with the intention that you'd be able to get them through their disease, and you were always on that mode. And what would happen then is that we would always reach the end of the ability to be able to treat the disease, and it was almost like you fell off a cliff. The doctor would come and say, there's really nothing more that we can do towards this, and it would be almost like an emotional or abandonment when the patient felt like, well, gosh, isn't there something you can do? Is there something some other way you can care for me? And so for many years, we were successful in being able to extend life and treat diseases. But then it was very hard. We didn't know what to do when we reached the inevitable moment when we cannot give a further treatment without maybe even causing more harm. Doctors, we really didn't know how to emotionally react to that. How do we take care of that patient then from that point on? How can we intensify our caring part of medicine? And so when palliative care came along, it was the kind of thing where we could continue on trying to cure or treat the disease or hold it back as long as we can, but in the meantime also begin to realize that we're reaching a point where it's becoming more difficult. The disease is beginning to win out, so to speak, in our ability. And we can help prepare people for that. But the mindset of the American culture is, wow, if you can't cure that, then there's something wrong. Something has gone wrong. And now you're giving me a death sentence that I'm not ready to cope with yet because we've not built up to that moment. We haven't helped them understand and foresee that eventually we will reach that point. And so the word hospice, in my 10, 11 years experience now in palliative medicine, is a very scary term that unless you approach it in the right way, people look upon it as you're withdrawing care from me now, you're going to take away my medications, you're going to put me in a room, either in my home or in a nursing home or in the hospital, and you're going to give me medication, and you're going to end my life very quickly with medicines. And of course that's not the idea, but what happens in that situation when you have that kind of mindset in the back of your mind, as soon as they mention hospice, they say, well, I'm not ready yet, because I'm not ready to what I perceive as dying in the next few days. And so they hold off, just like holding off a lot of times on pain medications, because if they go to morphine or a narcotic to help treat their pain, they feel like they're throwing in the towel, and that means it's going to be on the downward spiral, and they try to hold back on that also. So the whole approach of hospice care and palliative medicine is to try to help them come to that understanding of what kind of care we can do for them way far in advance, so that it's not so much of a surprise. Their family and their caregivers and the patients are more prepared to say, yes, I'm still fighting, I want my cancer treatment, or I want a surgery, or I want radiation, or any other number of things in the hospital care, but I'm also realizing that my body eventually will start to slow down and shut down, and I want then a system of care that can step in and help take care of me and my family as I journey through this. And as we'll discuss here further down with all the panelists, the other aspect of that is not just the medical care, but the spiritual care of the person, that we hope to, with divine mercy, supportive care, try to address those issues also as part of their suffering. But for the most part, even though hospice care started in England, in the modern era, it's been around for hundreds of years, but in the modern era, people still have that idea in the back of their mind that you're trying to take something away from me, and it's too soon, and I'm not ready for that, and so I'm going to wait. And a lot of times it does happen that they only receive that care for the last couple of weeks when they could have been weeks to months. In the traditional pattern of medicine, like I was describing earlier, a person would be living their life and they have their diseases and things like that, And the effort was always, doing as much as we can to cure, and care for, fight back a disease. And then we all of a sudden reached that end of the time there, and that's when a person would come into hospice at the very terminal stages of their life, and that's when they would pass away. So this period of time where that type of approach to care was a very short period of time. Whereas with palliative medicine, palliative medicine is more of an umbrella type of concept in end-of-life care, and that is we try to reach out to patients and families sooner during the course of their illness as it's progressing, and we know it's going to be a chronic disease. We're hoping to reach them sooner so that it's more of a slope like this, to where this is the curing and the intense acute care, but the palliative care is starting to come along here also, all part of the continuum of their total care. And so that by the time a person might be eligible or ready for hospice, they're already aware of the kind of care they can receive and the support they can receive. And most often, when you would be coming into this is when a person, if you look at the trajectory of a disease, usually you have ups and downs, in your cancer or your lung disease or your heart disease, you have setbacks all the way along. And so you come in with an acute pneumonia here, and you get taken care of, and you start to build back up, but your baseline of living and activities of daily living is starting to you never quite get back to where you were before. And then you have another setback, a urinary tract infection or a surgical emergency or something, and you build back up again, but because of your disease, making it unable to rebound and recover as far as you'd like, you see that the trajectory is starting to have a downward slope. Yes, we can keep taking care of you, but we see your needs are going to become greater and greater. And what palliative medicine does is it tries to help you and the family discuss why this downward trend is happening. I go into the hospital, I should be coming back where I was before, but I'm not. I'm at a new baseline. Why? Because you took care of me, you took care of my disease, you changed my medicines, I'm out of the hospital, why can't I get back up there, even with rehab? It's because the disease process is causing their body not to be able to respond as well and fully as we'd like, and it's the natural progress of that disease. But in this time period here, they're going to start to find that they need more help from their family or their caregivers. They might need a new place to live and receive their care, and there's a lot of stresses upon all the people that are going to be providing this care, and that's where we need to bring in the people to help with their planning of being prepared spiritually, financially, medically, of how they want to respond for themselves and their family as their illness progresses, because we know eventually that it will play out to God calling them home. And if we can intervene sooner rather than just right down here, there's a lot more opportunity to be able to help that person live as best and as long as they can and as comfortably, but also be prepared, and that's why we have the experts here, so that in a crisis situation you're not trying to react to a lot of different questions that are going to be thrown at you. So palliative medicine can start way ahead, a year or two before they need the last weeks, months of care under hospice care and before they die. So it's a more encompassing concept, long-winded way to describe that. I'm sorry.
We're talking about Catholic needs, and you know our Catholic standard of care that we've developed, and certainly a lot of it has come from the ethical and religious directives from the Catholic Conference of Bishops. Why is it important for a Catholic to be taken care of based on those directives?
Being called into the diaconate back in the late 90s, and also being called out of anesthesia into end-of-life care, I was beginning to realize how important it is in the spiritual aspect of caring for a person with a chronic illness, that to include the spiritual aspect of that. And I was seeing that, number one, it was going against my grain as a physician to embrace or be asked to assist in suicide or euthanasia or whatever. And as an anesthesiologist, I could be a very good euthanasia doctor. I have all the right drugs and everything else, but I could see that it was just the wrong direction. We weren't addressing the suffering for it. And even though we have a lot of good medicines, a lot of good techniques to try to treat chronic pain and the other parts of the illness that impact a person towards the end of their life, their breathing, their heart and everything else, there was a deficit of what in the aspect of the full amount of care that a person needs. So even though a person may be relieved of their pain, there is still a lot of existential suffering that was going on. And we tend to ignore the spiritual component of that suffering. And as Catholics, we look forward, as all Christians do, to our new birth. As we approach the end of our life, if we have true faith and we have a strong spiritual foundation, we can understand that, yes, I want to live, Lord, and I want to live as good and as long as I can, and I might endure some suffering, but I also don't deny the fact that this is a very finite world that I'm living in, and my body's very finite, that I look forward to and understand that my new birth will be to my eternal life of happiness. But people are very uncomfortable with approaching the spiritual part of the end of life because, number one, it means that you're kind of admitting that you might be getting close to the end of your life. And number two, there's all kinds of factors that feed into a person's spirituality and their experiences that either make them fearful of going before God in judgment, that they may never be forgiven. They feel like maybe they didn't live their life spiritually as well as they should have, and now all of a sudden it's the 5 o'clock hour, and maybe they're not worthy, or just that fear of the unknown, that mystery of our death and our new birth that is very frightful to people. So if you don't address the spiritual component, even if you're an atheist, there's a spirit in you that God put in us that cannot deny the unknown, that questioning about after I die, is that it? Is that all that there is? And so I think the whole, and I'm not sure if this is answering your question, but from a Catholic perspective, we have so many tools in our faith that can help relieve a tremendous amount of the suffering that medications will never begin to touch. And that is the sacraments and the rosary and the praying and reconciliation with God and your family and everybody else. So if you can incorporate that into the care, that's one of the most important aspects of it.
Lenny, first of all, let me ask you, what is some of your experience with end of life, just in general?
So some of my experience, and a lot of it more recently, is dealing with clients who are coming to me looking for planning for end of life care. And there's a couple of things that I notice almost every time I meet with a client. One is, and they're usually Catholic clients, one is there's a fear that there is this thing out there called the culture of death, and it's legitimate, perhaps it is legitimate. It's something that Pope John Paul II has coined, and we've all heard of this culture of death out there. And that really culminated in, unfortunately, in the time when I was in law school with Terry Schiavo. Everyone always says, I don't want that to happen to me. What happened to Terry Schiavo? So can we plan for that? And so on one hand, there's a real fear of, there's this bureaucratized and mechanical and scientific system out there that might just terminate my life without me knowing it. On the other hand, I also get the comment of, I don't want to be a burden to my spouse or to my kids. I don't want my expenses to be so expensive that I'm a burden to my family, something like that. And my response to them on both of those is that really a Catholic mentality? Is that the mentality that we have been given by our church and in virtue of our baptism? And I try to help them question this state of mind or mentality that they have towards end-of-life planning, okay? And that really leads to some critical questions, one of which is, what sort of duty do we have as Catholics to plan for end of life? Do we have a duty? And the answer to that is we do, and the church has a lot to say about that, and I'll try to kind of generalize it and sum it up in 4 points. The church clearly states, to the laity especially, and that's the question, does the laity have a duty to end-of-life planning? The answer is yes, the church has stated clearly in the Catechism that the duty of the laity is to order temporal affairs according to God's gifts first. That's our role. That's our responsibility in the church. That's our role in the apostolic mission of the church that the church has given to us. The clergy's role is to call us to that order, to order all of creation to the altar. And what do I mean by that? The examples that we have are in Scripture. In salvation history in the Old Testament, starting with Genesis, you have the scene of the garden, and Adam and Eve are given the duty to care for the garden, and at the center of that garden is a presence that is to be preserved. It's not even to be touched, and it's the presence of God. It's God's life presence within the garden. Everything is ordered toward it. So we know that we screwed that up. We messed that up, and the fall took place. We don't know anything until the third chapter, or the third or fourth chapter, are introduced Cain and Abel. We know nothing about Cain and Abel, other than that they're adults. One's in charge of the field, the other's in charge of the animals. And the first thing that they do right away is they make an offering to God. And it's kind of a clear connection to an attempt to restore what was lost. We want to preserve a portion of creation, preserve that, and it's not to be touched, it's to be offered to God, to preserve a space for God. And it's the space for God that we as laity are called to bring to the altar. We're going to get to that in a minute. Throughout the rest of Old Testament themes, some of the major figures in Old Testament, from Cain and Abel to Abraham, to Moses, Noah, Jacob, David, there's this constant theme there where God is always calling his people to order all of our affairs to him, to order all of our affairs to the Father. And eventually the Father then comes to a statement or proclamation that I don't want your holocaust, I don't want your offerings, I want your hearts. I choose man to be my dwelling place. And the fulfillment of that, as we know as Catholics, is in the person of Jesus Christ. So in Jesus Christ, we have his pure gift of life from the Father that we know as Catholics, and kind of cut to the quick, is the space in which is preserved as a sacrifice to the Father, and the Father's gift to us to be in communion with the Father and have this Trinitarian relationship available to us through Jesus. Why is all that important? That duty to order temporal affairs is exactly what we celebrate on Sunday or in any Holy Mass. The priest is calling to order our creation as laity, our work to the altar, to bring that to the altar, to unite that to the sacrifice of Christ. So when it comes to planning and preserving that space for God's presence at a time in our life when it's most critical, when we're most vulnerable, then our lives and our planning ought to flow directly from that reality that we have as Catholics. There's also a duty to the culture, and we've heard culture of death, there's also culture of life. So the family, the church teaches us, is the first and vital cell of all natural society. And it's within the family that we learn the love of the Lord and how to respond to it. So the family is vitally important in this planning as well. We should be including the family in our planning. And oftentimes, the consequence of not planning for end of life has a direct impact on family members. And family relationships is where it may hurt the most. And we've all maybe experienced that in our own families or in the history of our families. So with family being so important and ordering towards the good, towards the true, towards the beautiful, towards Father, towards Jesus, towards holiness, we create that space within that planning. We invite our family to that planning, and we have a duty in our culture to proclaim that reality. What do I mean by that? Culture of death. You can talk about the culture of the death in the context of we have rights without duties, right? I have a right to define myself. I have a right to define my relationships. I have a right to have God on my terms. And we understand that as relativism and those those problems that are self-destructive in the culture of death. The church offers the solution on the other end of the spectrum of a culture of life. It's rooted in that reality of the liturgy, of communion, of self-gift, of communion with the Father and the Son and the Holy Spirit, which flows into our understanding and informs our family life, which can flow into our practices. So how are we to manage things as lay people with our time, with our talent, our treasure? We hear about stewardship, but all that's ordered towards the altar. It's ordered towards uniting ourselves to Christ. He wants all of us, 100% of us. So we also have a duty to the sacraments in that respect, that we participate in the sacrament of the Eucharist especially, but also that we are baptized priest, prophet, and king. We're baptized into the death of Christ, the church teaches us. And it's that gift of faith that is sustaining us through life, through death, and to life eternal. So we have then a duty to respond to that call that we've been confirmed and baptized, and we are to respect that sacramental reality. And also within the sacrament of marriage, that we've promised our spouses that we will be a complete gift of self, and that we will also care for our spouse, and their life will be in our hands, and our life will be in their hands. So oftentimes, and that relates to that, I don't want to be a burden to my family, but I try to kind of teach or get them to think about, well, what is this sacrament of marriage that you've entered into? So those do, and then finally we have a duty to the legacy of our faith, right? And that's part of our planning as well. Through this process of planning, through this experience of end-of-life care, can be the most powerful and meaningful time in which we are handing a legacy over to our kids regarding our faith in the Father, and that we are not afraid of death. So, summing all of that up, the point being the church does, in fact, say we have a duty as laity to plan for end of life, and that should be a very beautiful spiritual and sacramental experience. And we can include all of those things in our plans. We can include those things in our documents. We can write within our documents that I want family members to be praying the rosary next to my bedside and for the sacraments to be present. Okay, thank you.
So I'd like you first of all to describe, as briefly as possible, the differences between a living will, an advance medical directive, and a power of attorney.
Actually, the Colorado Revised Statutes actually talks in terms of those three types of categories. The living will is a document which, at its base, is to some extent self-executing, because it's a statement that you make while you are in good health, competent, stating what your wishes would be. And the law now in Colorado is changed such that it incorporates the Terry Schiavo situation, persistent vegetative state, or terminal illness. And specifically with respect to extraordinary health care, with respect to nutrition, and with respect to water hydration. If that document is properly prepared, signed, witnessed by two individuals, and then a doctor then has determined that you are at that point, and then another doctor confirms that you are at that point, persistent vegetative state or terminal condition, then at that point they are obligated, the statute says, to notify family members that they are about to implement the living will. And then 48 hours must pass after their certification to give an opportunity for family members to then potentially object to the living will, that there's some basis for the objection, that it wasn't a valid living will, so on and so forth. And then after that, the doctor, the treating physician, can then take action with respect to withdrawing life support. It's interesting, however, that in the statute itself with respect to life support, because it's like any one of these areas where it's very difficult, gray areas as far as really what and when does the patient want this to have happen, that the statute actually talks about the physician looking and inquiring with respect to other family members with respect to when to make the final decision in terms of direction. Not obligated to have to do that, but should make inquiries with respect to what the individual's wishes were. I thought that was kind of interesting, that it's not quite so black and white. Many people that I've talked to, especially within the clergy of the church, are very concerned about the living wills because of the fact that they have that sense of maybe giving up of the control that perhaps you would want to have in terms of when exactly that would happen. And it might be in the hands of somebody who is not a Catholic, who does not share the same types of values. And as a result, many people will say, I don't want to have a living will. Now, this is very interesting because when you go into a hospital, what's the first thing that happens when you go to admissions? They will say, do you have a living will? They don't say, do you have an advance medical directive? They don't say, do you have a healthcare power of attorney? And of course, if you don't have one, they pass one across the counter, say, here, sign this one. And I find that to be very interesting, but at any rate, many Catholics feel as though rather than having a living will, what they really want to have is a healthcare power of attorney. And a healthcare power of attorney is an expression of desire that, again, you make while you're competent and well enough to do it, indicating that you wish to have a designated individual make these very important healthcare decisions when you're unable to make those healthcare decisions. I always tell my clients that you name one person. You name two people, and I've talked to doctors about that, and two people will disagree. And no doctor wants to be in the middle of some sort of yes-no scenario, because then they're going to go say, I think you should go to court and have somebody appointed as a guardian to make the decision. So we want to avoid those complications. So as we explain to families, no, just one person will make the decision. They consult with family members, of course, before making the decision, but they're the ones that would make the decision. Now, having said that, the medical power of attorney gives them the power, including the withdrawal of life support. Gives them the power to consent to medical surgical treatment and even change who the treating physician would be, or who or where that is going to be. They could say, we're going to take you to Mayo's. We'll see, that's the court of last resort. We'll see if, in fact, they agree that this is the end. They could do that. Now, while you're given all this power, it doesn't say a lot about what exactly the patient wanted to have happen. And there's no instructions in the purest of the powers of attorney, most often. Just lots of powers of what they can do. The Advance Medical Directive portion of this is something that can be inserted into the healthcare power of attorney, which are instructions with respect to exactly you would like to have happen at different times with respect to palliative care, with respect to surgical treatment, as to when the end is going to approach. I've been doing this for a number of years, and actually over the many, many years I've been doing this, I have asked clients to write out instructions as to how they would like to be cared for, and I give them a legal pad, and of course I would get back mostly blank, but what I have discovered over time is, having collected hundreds of instructions that clients have written and kind of made them kind of generic, I now give them a checklist of 50, 75 questions that they can check the box with respect to things that they would want in terms of instructions, because they don't know what to write. They've never died before. They've never had a serious health condition. And so having kind of a opportunity, I say it's easier to edit than it is to create sometimes. So giving them some ability to be able to insert instructions that they think is appropriate for themselves is very helpful, especially when you're doing the healthcare power of attorney. Now, having said that, you can also have advance directives in the living will. I take the position with somebody who's very strong about wanting to have a living will, because after all, the hospitals pound on this so much, that we can overcome perhaps that situation where the doctors will be making the decision independent of what your wishes are by having the directives in the living will. So I have actually done this both ways. I've had the directives in the living will, I've had the directives in the healthcare power of attorney, and it's really something of an individual choice. The one thing that I would mention, however, is that the statute, in the living will statute, says very clearly that if there's any conflict between the living will, in terms of what it says, and the healthcare power of attorney, the living will, with respect to issues of end-of-life issues, will control. So if you're doing this, you have to be very careful. And so I'm kind of a wordsmith, so to speak, when it comes to these kinds of things, and being very clear in your intent and your wishes, and making sure that what the client wants to have happen, and ultimately control over when this is going to happen. With respect to the particular aspect of the Catholic philosophy portion of this, I've been doing a little bit of research, and again, having specific instructions, especially for Catholics. And I drew upon the source of the United States Conference of Catholic Bishops and the 5th edition of the Ethical and Religious Directives for Catholic Healthcare Services, and I incorporate this as an attachment addendum that either goes in the living will or the healthcare power of attorney. And the purpose of this, because I know it'll be read either by the agent of the healthcare power of attorney and or the doctor and, of course, the family, but clients come to me, the persons who are going to be making the decision, what do we do? What can we do? It's like if you ask anybody in any situation, it's like they're going to have two different opinions about when we should do this or that, and they feel guilty about the decision they're making. They want to feel comfortable about whether they're making the right decision. Ultimately, as to when the end of life, and there's some very good language that is in these instructions that, again, I incorporated into kind of a check-the-box kind of thing. And I just would mention maybe perhaps just a couple of these. For instance, Directive number 56 in the Ethical Religious Directives, I think would be helpful for someone if they thought that that expressed what their desire would be. It says, and again, you would check the box if you agreed to this, I believe there is a moral obligation for care providers to provide me, that's the patient, with ordinary, proportionate means of care that will be preserving my life. Proportionate means are those that, in my judgment or the judgment of my healthcare agent, under my healthcare power of attorney, offer reasonable hope or benefit and do not entail, and here's the key thing, excessive burden or impose excessive expense on my family or on those persons responsible for my health care or the community. Well, now does that tell you what to do? No, but it gives you a little more in the way of guidelines with respect to what you're supposed to do. And there are other directives here that talk with respect to even more serious types of situations, but this really all comes down to a question of what is conscience and moral conscience. And if you read the theology with respect to the Catechism, the Catholic Church, in terms of conscience, there's a subjective and objective portion of that conscience that melds together in terms of what is the real will of God in this situation. The best that we can do for clients is to perhaps provide them with some counsel, some guidelines, instructions, direct them in the way of our deacons and priests. I'm more sensitive, however, to the professionals of those of you out there that I'm looking at in terms of what do you do with an out-of-control family, and you've taken care of this patient for years. You love this patient, or maybe you don't love this patient, but they're still your patient. And this family is trying to tear this patient out of your care and telling you what to do. Maybe there's 2 or 3 of them. And the L word begins to be mentioned. lawyers, lawsuit.
What are going to be love?
That wasn't in the vocabulary in law school. But, so what do you do in that kind of situation to protect yourself? And so I feel very compassionately for you. I mean, you have the medical ethics committees in the hospitals, obviously. But who do you turn to with respect to what are you supposed to do? You know, this is your livelihood, your profession. And so each situation is so different. There isn't a book or instructions as to what it is you can do. About the best that I tell my friends who are in this profession is I give them my card and say, you know, call Lenny, call me. But, you know, if you called either of us and said, you're a member of the Denver Guild of the Catholic Medical Society and you have an emergency, I'll bet you get me out of a meeting because I know what's happening. Now, will I be able to tell you what to do? No, but I can give some advice as to what the legal ramifications of the circumstance that you're facing, so perhaps you can make a better decision or be in an opportunity to make a better guiding counseling opportunity with respect to a family, because it must be a frightening thing to have to face with respect to this patient who is ending their life and there's this drama being played out around them.
Sean, I want to move to you. Sean is like this wonderful young guy that I had the opportunity to run into a couple of months ago in some odd setting, and he's one of the most impressive young human beings that I've ever met. He is a volunteer. He has hours and hours and hours of hospice volunteer. He's been with many, many, many patients as they've passed on, and he's really an incredible guy. And in our business, in any hospice business, we need tons of volunteers, people to sit with people and just to listen to them, play guitar, let them listen to some music, play cards, say the rosary, whatever. Denver Hospice, I think, has 400 volunteers, so we have a lot of work to do with respect to filling up that sheet. But Sean, could you just kind of enlighten us? First of all, I'm interested to know, what motivates you to put yourself in that position to begin with when you could be doing other things. But when we started talking way back when about the Catholic portion of our business, it really excited you. So maybe just give us a general overview of what is it like to be a volunteer? What is the Catholic part of this going to do for you with respect to your enthusiasm as being a volunteer?
Sure, thanks, Mark. So before I get into that, I'm going to keep this short too, by the way. I have one question for the audience, and I know we have a very smart group out there tonight, doctors, lawyers. So anybody can take a shot at this. And the question is this: what is the leading cause of death in this country and most other industrialized nations? Does anybody know? The leading cause of death. Here we have a heart attack answer up here. The correct answer is actually birth. So if you're breathing, you're leaving. So the first thing you have to realize is you will be a hospice volunteer for somebody, either yourself, obviously, or someone else close to you in your life, family, friends. At some point, it will become relevant to you to have the skills necessary to be a hospice volunteer. So for me personally, what attracted me to the Catholic model of care as a hospice volunteer, I come from the world of the VA. I've been with 63 veterans passing away. It is a very secular world, and in lots of ways the volunteer can be secular. It's not the spiritual person or the clergy or the chaplain that you'll find in most volunteers. It's the person that listens. I'll listen to a Buddhist the same way I'll listen to a Catholic. What's great about this model, though, is it gives me an environment where I can express my faith with other Catholics. In the VA, I listen. That's what volunteers do. You listen. You provide compassionate presence. You can do that whether you're a Catholic, whether you're a Buddhist, whether you're Zoroastrianism. I mean, whatever you're into, whatever your thing, you can do that as a volunteer. But this provides the environment and the space to listen from that point of faith. I know I'm going to be talking to other Catholics, and I can call on a priest. I can have a nun or a sister come in and explain to them what the church says. That's not the volunteer's job. My job is to listen, to show up and be present. If it's a question of faith, I'll call in the priest. I could take a shot at it, but that's not what the volunteer does. We listen and provide compassionate presence. So why is this model so great? because it creates that space, that environment where you know you're going to be supported. There's going to be there people you can talk to about your faith, and if questions come up from the patient, you can bring somebody in that knows that.
Thank you, Sean.
And one other thing, I see a room full of potential hospice volunteers out there. So, you know, is it Brian? Who should people talk to, Mark? I mean, ask questions.
We need to talk to Brian.
Yeah, talk to Brian. I'm with a group called the Twilight Brigade. It's it's about 20 years old. It's in 9 VAs, but it's accredited by the National Hospice and Palliative Care Organization. About 6,000 volunteers, and there's a training in late April. TheTwilightBrigade.com. But that's how you get involved. Take the step. It will change your life as it changed mine.
Thank you, Sean. Could you pass the mic down to Deacon Jerome? Appreciate that very much. But I wanted to ask you about your experience with end of life. We know deacons, you could administer communion, Viaticum at that particular time. No anointing, no confession, obviously. But you shared with us an experience you had at a presentation we did a couple of months ago where you were with a patient who was dying, and I wondered if you could just take a minute to share what that's like, somebody who's Catholic receiving those sacraments at the end of life.
Sure. First of all, I believe hospice care is a great gift to those that are dying because it allows a person an opportunity to reconcile with God, to reconcile with their family, their friends, and with the world. And it's a time where they can receive the sacraments, receive the sacrament of anointing. As Catholics, what makes us specifically Catholic is the sacramental life, that we get to enter life with Christ and in Christ and for Christ. And when we are baptized, we are anointed into new life. We receive this great gift of life and we are anointed then. And in confirmation, we are anointed for courage to be able to take on the battles of life. And the anointing of the sick fortifies our soul so that we may be ready and prepared to meet God. You know, St. Paul tells us that we are aliens in this world. We don't belong here. We belong to God. We belong to the kingdom of heaven. And that's where we're all destined for in our eternal life. And that's what baptism promises us. So when we go as volunteers and we go as ministers to visit people who are dying, we listen to them, we talk with them. But when we can bring them sacraments, they have tears in their eyes because they realize that they're bringing in Jesus and that their life is coming to an end and that their promise of baptism is about to be fulfilled where they can enter into the heavenly kingdom. So when you go somewhere and you know that a man or woman is dying and you take them Holy Communion and you pray with them and you see joy, true joy in their life because they've received Christ. They've received, they're coming to the culmination of their faith. You know, it's true what we do. It's true that we are baptized. It's true that I've made a good confession. It's true that God really loves me and He is my Creator and I can now join Him. Our faith is so beautiful. And for people who are Catholic especially, who reach the end of life without receiving the sacraments, without having the opportunity because it wasn't offered to them or it wasn't available to them, or a priest couldn't come because he was so busy, it's a shame. Hospice care is so important for all of us that we should all just be running to go volunteer, to go meet Sean and men like Sean and women Sean. And, we have a program that we wanted to develop with training volunteers because volunteers need to be well trained, but they need to be well intentioned too. To be able to come in, and to love their faith, to love Christ, to love the person placed in front of them. so that we had background checks and those things too, that for volunteers that will, be on this conversation. But volunteering and participating in the life of others is what we're called to do as baptized Christians. When we are baptized, we are set on a mission. Today's gospel says, Jesus, they're looking for you. All the people are looking for Christ. We are all still looking for Christ. And where do we find Christ? With each other. In the love of God that radiates through us, through the Holy Spirit. So, to be present to those that are dying, to be with their families, it's hard. We will be guided by the Holy Spirit. Not everybody understands what we do as Catholics. Even Catholics don't understand a lot of times what we do and why we do it. But it's also a great and wonderful time to evangelize, to spread the good news, to say to other family members, this is why Aunt Rose prays her rosary. This is why Uncle Tom goes to Mass every day. This is why the person dying in front of you loves Christ. And he wants you to love Christ too. And to know Christ. And to know God. So to participate in that wonderful time of life should bring us joy. And should bring the dying person joy. It's a difficult time, but I think when you're with people that are dying, they're not necessarily concerned for themselves, they're concerned for those that they're leaving behind. Because, especially if they're strong in their faith, they know that Christ loves them and their reward is great in heaven. But they want that same reward for those that love them. So when the person does finally pass on, and we do come to their funeral, and we can participate in that life of Christ at the funeral, but then all those people that come to say their farewell are there to hear the love of Christ present to them as well, so that they know that they can enter into the communion of saints. And that's our destiny, that's our goal, and that's who we want. We want to be with God, with our loved ones that have gone before us. But most of all, we want that eternal joy. The communion antiphon today was, I come to give you life so you may have life more abundantly. And that's what we want, is the abundant life. So thank you.
Thank you, Deacon. We have two more. So Lloyd I know very well under unfortunate circumstances. He buried my mother-in-law, my father-in-law, and my sister-in-law. So we went out to visit him a couple of months ago, and he just does such a magnificent job, and so many things for the unborn babies that go on that you don't even know about. So many things for the indigent. And the question I wanted to ask you, and I might only be able to ask you one, why are the rites, customs, and practices of the church so crucial for the deceased as well as the survivors? And this has to do with why is a Catholic cemetery so sacred and all those types of things. So.
Sure. Thanks, Mark. In canon law, there's two places considered sacred. There's the worship space and the cemetery. And we as Catholics have a duty in two things: the corporal work of mercy, first to bury the dead, and the second is the spiritual work of mercy, to comfort the grieving. And so we almost have a two-pronged mission at the Archdiocese of Denver Mortuary. Vince and his work, those who are working for religious organizations. Our duty is to pray for the dead. Our duty is to pray for the repose of their souls, so that we can ask for God to forgive them of their sins, for in their heart they desire to do well, and welcome them into His kingdom, and to provide that place for people today, because we are in a death-denying society. A friend of mine says, I'm not about to come out there and pre-need my funeral, because sure as I do, I'm going to come down with something and I'll be back in a couple of months and I'll be dead. And I have to convince people all the time. Vince can relate to that. It's not necessarily so. We live at a time today when people want to hurry it up and get back to normal. We don't want to spend the time like we did back when many of us were growing up, where you'd spend 2 or 3 days at the funeral home, and thus the term home. You spent there 2 or 3 days with your family. You ate there. You were there from morning till night to receive friends and grieve. Today, people don't want to grieve. The counselors in the room, the therapists in the room know that people don't take the time today to grieve properly. And when you don't grieve properly, we're walking around today with that sadness, with that loss that we've yet to deal with. One thing we know about grief is that grief will wait for you. So you can put it off as long as you want, but someday it will come back. And when it does, it'll be on someone else's terms or by some other direction that you're not prepared for. So at the Archdiocese of Denver Mortuary and at Mount Olivet Cemetery, our duty is to first take care of the dead. And we do it with dignity and respect always. And that's first and foremost. We're there then to serve the family because we want to guide the family towards grief. A man called me a week ago. I was on call for the mortuary. He says, I want the quickest and easiest way to get rid of my mom that I can. Swear to God, that was his exact words to me. I said, well, sir, if that's what you want me to do, I can't help you. But if you want your mother treated with the care and dignity and respect that she deserves as a child of Christ, and you want it done in accordance with the norms and the teachings of the Catholic Church, you have called the right place. And eventually we were able to get this person to understand the importance of why we do what we do, why these rituals are so important, not only for the dead and to pray for them, but so that we as survivors can heal properly and the word closure doesn't exist. They want to throw the word closure on. We need closure on this. Well, closure won't happen because closure is something that's elusive because we're never going to fill the void left by that person. We can desensitize to it over time, but that loss will always be a part of us. But if we do it right, it won't be as bad. The other side of that, is our spiritual work of mercy of comforting the grieving, because it doesn't stop there. When we get done with the Mass and the importance of that Mass, to pray for the repose, to ask for forgiveness of sins, and remember the death of Christ and how we're in union with that death. But then at the cemetery, there's something about the cemetery rites that there's a piece of finality to that is the toughest part. And I always ask families, well, we want to watch the casket go down into the ground. And I say, are you sure? Because there's something about that moment that it really hits home that, yes, my loved one really is dead and they're really going into the ground. Or do you want to step away from that graveside service knowing that we've done everything we can for this person? We've asked God to forgive and best to leave that memory of that casket on that device and knowing that that's their final resting place with all the things that we do. And so it's a really important ministry. It's one that we have a duty to make sure that we usher that deceased into heaven and to comfort those families and survivors that are left behind. We also, Mark asked about babies, and I'll be very quick. We know that life begins at conception. And at the Archdiocese of Denver Mortuary, we go around the city, whatever the hospitals call, we gather the fetuses who have died. Whether the fetus was a week old, whether the fetus was 23 weeks old, whether they were a week from being born. The hospitals know to call us. We can't get the aborted fetuses from the various abortion clinics because that would offer dignity to those children. All we can do is pray for them. But we gather these children once a month. We have one of our employees that's his specific job is to go out and pick up the babies. We encourage the parents to name the child because we have to put a name on a death certificate. We then bring the babies back and we keep them in our office. They're at a very high place of honor in our cooling facility. We have a group at St. Francis Cabrini Parish who knew of our ministry, and all the women from the Ladies Auxiliary of the Knights of Columbus began making these pouches and they crocheted them. And the pouches could be in size from something this large to something very, very small that a tube of fetal tissue or a specimen jar could slide into. And we keep we have a dresser downstairs at the mortuary where all these pouches are kept. And the men heard about this ministry that the women were doing, and they said, well, we want to build the caskets for you. So now the Knights of Columbus at the parish and parishes in that deanery are also building the caskets, and they deliver them to us whenever we need them. And once a month we have a communal burial. All the families are invited out. We offer a priest, and maybe someone has a relative who's a priest or a deacon, to come out, and we do a graveside service for all the babies once a month as a communal burial up at Mount Olivet. And we take that very seriously. We also are the only ones, not the only ones in the city, but we take care of 95% of the non-veteran poor in the Denver metropolitan area. So when someone dies and they have no family, nowhere to go, they're on Medicaid, have to go to social services, we bury them. I know that Vince's organization buries them too. There are some who do. There are some cemeteries who accept them. Many won't because there's no money involved in it. And it's our duty as Catholics to take care of those people just as those who we love and we know. Another rule we have is that none of those people will go into the ground without prayers being said for them. We can't hire a priest. There's no funding for that. Myself or our director, we have the same book that the priest or deacon will read out of. We go out and say the prayers. I may not even know that person's name, but our duty is to pray for that person, to ask God to forgive them of their sins, welcome them into his kingdom, and for in their heart they desire to do as well. So it's a ministry for us. It's not a business. Yes, there's the business side of what we do, because we have to support the greater church. But that's what we do. That's why we exist. But we exist to take care of the dead in whatever form they come to us in, and we take it very seriously.
Thank you for what you do. Thank you very much. If you could pass that down to Lillyn. The voluntary portion, the bereavement portion, it really has nothing to do with hospice, but we are dedicated to trying to bring education to all end of life for Catholics. And Lillyn is the music and bereavement director at Notre Dame Church. And one thing that I'd like to say is within the hospice benefit, within Medicare, there's a 13-month bereavement benefit. People never take advantage of that, and it's something that's very necessary. So it's available for you. Everybody here who's eligible for Medicare has already paid for these benefits, so I just encourage you, if in fact the time comes, to understand that, even if for someone else. But anyway, it's important to understand that whole grief process, that understanding, or that accepting, those. So just tell us about bereavement. Tell us, what are people, mostly their challenges, the biggest challenges you can think of?
In bereavement, in the grief process, is accepting that they're going to grieve. Most of the time, at the time of death, people, and I'm so happy to hear Lloyd say, we are a death-denying society. We do it in every form, in all aspects of our life. When we talk about death, I'd like to get a little bit of feedback from you. What are the things that you hear when someone has died? They're in a better place, okay? They passed on. They went to sleep. I mean, those are the things that we say. We never, for the most part, 99.5% of the time, I never hear someone say, my loved one died. And I had a woman who was grieving. Her son was murdered a couple years ago. And she was irritated and aggravated because every time somebody would say to her, I'm so sorry you lost your son. And she said, really, will you help me find him? Because she wants him back. So our language really reinforces the whole concept of grieving. Instead of saying, my loved one died, we will say everything else to soften it and to keep it at bay, so to speak. But the reality is that we are death denying. And so what my goal is through the bereavement process is to help the people. And we just, at my parish, I do a 6-week grieving session around the holiday season, because it is exceptionally difficult for people who have lost a loved one to death in the past year. And so I just give them tools. I give them things that they can talk about. I like to do education ahead of time. I tell my parish, and I do things throughout the year, bereavement education, I do death education as far as pre-planning for funerals, euthanasia. I've had Deacon Allen out a couple times. And it's education. We need to educate not only ourselves, but the people that we are ministering to within our parishes about what the church teaches around euthanasia, about what is acceptable at the time of death, what are living wills, what are living trusts, what is a will, when do those take effect? Most people don't understand what a power of attorney is, and so anything that I can do, and the worst time to do any sort of education is at the time of crisis. When someone you love is dying, the worst time to try to prepare for that is in the crisis, because you end up doing things that you otherwise probably wouldn't do because you're not thinking clearly. So I'd say to you, when you leave tonight, go out, find someone to talk to, a good attorney, your pastor, maybe you have a parishioner at your parish who's someone like me who can help you with that process. And I tell my grievers, it is lifelong. They think that it's going to be done, they'll be done in a year. And then I get women who've come after 2 years and go, I don't feel any better this year. It's the second year. Everybody told me I'd be better after the first year. And they're angry. And I say to them, you're exactly where you need to be. It's just an acceptance that grief is lifelong. Mourning is a short period of time. We're bereaved because we've lost someone that we love and care about. But how do we take that grief and incorporate it into our lives so that it makes us more loving and more wise, more holy? And so my hope is through the bereavement process, through the grieving process, and the groups that I have, that people will get some care, they'll feel some solace, and most importantly, what that greatest commandment is, to love God with our whole heart, mind, and soul, and then to love our neighbor as ourselves. So that's kind of my philosophy. Thank you.
Thank you.
Short and sweet, wouldn't you say?
I think it is, you hit on the head that the Holy Spirit is the one that's just been kind of pulling a lot of people on parallel paths. I think for quite a long time, especially as the euthanasia and assisted suicide issues have been coming up. Like I mentioned earlier, there's a palpable void of good end-of-life care that incorporates the spirituality with it, even though every hospice agency is supposed to do that. And so, as I was evolving into palliative medicine with my practice in Kaiser, I had this urging not only to do the medical part and try to help relieve pain, but also the spiritual part. So being called into the diaconate, those two ministries really dovetailed together well so that I could also help people on their journey. And from my perspective, what more important part of our lives is that new birth, the time of our new birth. If you can help somebody be that 5 o'clock servant, like I said, and help them gain the eternal rewards of heaven, what a timing of your life, their lives you can be impacted on. And then the Divine Mercy group that was kind of having the same tuggings, same urgings, have been kind of thinking about this all along for some years. Many people that I've been talking to, when they hear that, you know, I'm a deacon and I'm a physician and I'm working with end-of-life care, they say, oh, that's so much needed. I mean, the Catholics, the Christians are really crying out for the ability to be able to relate in their prayer life and in their diseases to their faith that they grew up with, even if it wasn't real strong. The other parallel path that's been happening has been not only care for the indigent and uninsured, you know, who may not be able to afford a lot of the services that we want to give to them, and not have the spiritual part of it, is for the retired and elderly clergy and religious that oftentimes are journeying through the end of their lives alone because they're retired. They haven't been able to set up their financial affairs as well as their estate and be able to live comfortably with a very meager retirement income. And a lot of them are dying alone because they don't have advocates for themselves, they don't have their family with them. And there are some priests right now, and the diocese itself is, of course, very interested in trying to reach out to the retired priests and religious to provide them an atmosphere wherever they're living, or to provide a living facility for them to come and be in community and to be able to feel purposeful and to live out the rest of their incredible vocation under a Catholic atmosphere. So that's been kind of a parallel course also. And all those are starting to come together in a remarkable way that we would have never met. I mean, so many people have been coming into my life and everybody else's here, as it can't be nothing more than the movement of the Holy Spirit bringing it. And we want to bring more and more people into this so that I think it's going to be a groundswell of support down the road for people to want this for their loved ones as well as themselves. And especially, we know the attack against life this is the next front on the culture of death is the push for euthanasia and assisted suicide. It's going to be voted on in this state, I'm sure, in the next year or two, as well as multiple other states. And if we aren't prepared for that, to be able to care for our loved ones the way we want and in our faith, then we will lose the battle. There's so much division and controversy about food, assisted nutrition and hydration in patients, that I just tell them that it's a very individualized thing, that you have to approach it from, to just be brief enough about this very extensive topic, that not everyone will benefit from an IV or a feeding tube, and there are many people that will benefit from a feeding tube and an IV if it's medically indicated and it can help them in their quality of life and everything. So it's not the Catholic Church has been accused of wanting to put breathing machines and breathing tubes and IVs and feeding tubes in everybody and keep them alive forever, and it's not that situation at all. It's really weighed upon the burden of providing it, and will it provide them with care, or will it make them more uncomfortable? And you have to really weigh each individual situation, and in this particular patient's case, will this help them out? And we are obligated to give them, not allow them to die because they were starved to death and that's the only reason they were dying. But a body will starve itself to death even if you do provide it sometimes, and that's what you have to weigh, both those benefits and burdens. So it is, you're right, Bob, it's a very difficult, controversial, gray zone situation that you really have to weigh medically what their organ systems are doing, how they can assimilate the fluids, and will it be helpful to them, or will it actually cause them more harm? But as time goes on, there is going to be a push, I think, for utility purposes, resources, and everything to want to yank different things that might be helpful and not provide those. And that's where we have to step in, I think, to say, it's a relatively reasonable and simple way to provide them with some care, and or to say, really, we can't honor that wish to put a lot of fluids into them because it will fill their lungs up or their tissues up or make their kidneys fail faster or that type of thing.
All we ask of you is for your support. If you think what we're doing is important, if you know somebody we should be talking to, if you have a group of people that we should be doing a presentation to, any support that you could give us would be very, very much appreciated.